And I think we're going live in 1 minute. Okay. There we go. So my name is Gail Wright, and I'm president of the Canadian PBC Society, a support group for PBC patients and their families. I'd like to welcome everyone to our first PBC Speaker Series event of 2022. As many of you know, today is International Women's Day, and we'd like to acknowledge the work of two pioneering women who are internationally recognized for their contribution to the study of liver disease, including their work in the understanding and treatment of PBC. And they are Dr. Jenny Heathcote and her mentor, the late Dame Sheila Sherlock. Tonight's guests are part of the next generation of dynamic women in hepatology, and we are thrilled to have them with us. Dr. Marlyn Mayo from the UT Southwestern in Dallas, Dr. Aliya Gulamhusein from the University Health Network in Toronto, and Dr. Puneeta Tandon from the University of Alberta in Edmonton. And to start things off, I'd like to turn things over to Marlyn.
Thank you. I'm gonna try to share my screen here and hopefully things will work. Give me a minute. Okay, is that sharing?
Yes, it is.
Working perfectly? Wonderful. So first, I want to thank you for the invitation to speak at this, and I found the subject matter very intriguing. As you say, this was formulated to honor women in PBC for International Women's Day, and this is Women's History Month. And so I tried to think of a topic that would relate to that. And the best thing I could think of was to do a battle of the sexes in PBC and talk about how the disease is different for men versus in women. And I didn't know you were going to mention these two lovely ladies, but when I thought about women's history, by far and above, the two most important people in PBC that came to mind immediately were Dame Sheila Sherlock from King's College in London, as well as Jenny Heathcote from University of Toronto. Dame Sheila Sherlock passed away several years ago, but she was a force that was larger than life, a very boisterous woman, very opinionated, who really took pleasure in taking on the men in her male-dominated society of hepatology. And she wrote the original description, really, of a cohort of women in the 1950s that had PBC. So really described it and named it for what it was. She wrote about using bile acid binding resins like cholestyramine to treat itching. That was, pretty much her idea. And she trained many of the world's leading hepatologists. And one of her trainees was Jenny Heathcote, who went on to become also a great force in hepatology, and particularly in the field of PBC. And she conducted the original clinical trial of ursodiol, showing that this helped in the disease. She really authored hundreds of scientific papers on PBC and was probably one of the most important educators of physicians. She was a wonderful speaker, and you couldn't go to a meeting in the United States or Canada or Europe without hearing her speak, because she was such a wonderful speaker. She was always chosen to be the one to educate others about PBC. And then she has retired, and she passed her patients and research materials on to Gideon Hirschfield, who you may also recognize that name. So he is her protege. All right. So PBC, as you probably know, if you've done any reading, is a female predominant disease, and only about 1 in 10 patients is male. But we really don't know the reason why this is. What is the cause for the female predominance? We've considered, could it be hormones? And some evidence supporting that is we really don't see PBC in children. In fact, even the few children that are reported were actually teenagers or tweens who had already had their first menstruation period. So there really are no prepubertal cases at all of this disease. There's no 5-year-olds that have been diagnosed with PBC. There was also some literature in the older literature that this disease was often discovered during pregnancy, and could the hormones be stimulating it? But it turned out that in fact, pregnancy just on its own has effects that will increase itching and make people a little bit more cholestatic, and doesn't actually influence the disease at all. People have considered, is it something that has to do with the X chromosome? Because women have 2 X chromosomes and men only have 1. And in women, even though they have 2 X chromosomes, the genes on one of them is always silent and the other one is active. So if there were any uneven silencing of X chromosome genes, that could potentially lead to the disease. The problem is that many people have looked for this and nobody's been able to find any genes on the X chromosome that seem to be responsible. Now, autoimmunity is almost always greater in females. And again, we don't completely understand the reason for that, but is it just that because PBC is an autoimmune disease and therefore it's going to be greater in females? The only problem with that being the complete explanation is that a 1-to-10 ratio is even greater than we see in all the other autoimmune diseases. So it seems that there's something more than just the autoimmunity. And then finally, people have wondered, well, are there environmental exposures that women have that men don't have? There were some well-publicized questionnaire-based studies in the early 2000s looking at all different kinds of exposures and what might be associated with PBC. And they looked at things like tobacco, and some things that popped out that seemed to have a slight increased risk were things like nail polish and hair dye. But they were very, 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 very small risk factors, and they don't at all account for the size of this difference. All right, so I'm going to show you some data on how PBC behaves in men versus in women. Most of the data from this that I'm going to show you comes from this article, which I think is the best one to date, The Impact of Age and Sex on Response to Ursodeoxycholic Acid and Transplant-Free Survival in Primary Biliary Cholangitis. And this was work that came out of the Global PBC group. If you're not familiar with that group, it's a collaboration of investigators from all over the world. I'm a member. There are members from Canada, from United States, from the Netherlands, France, Spain, Japan, all over the world that have contributed data on their patients for the purpose of better understanding this disease. And in this paper, they looked at over 4,000 PBC patients that were treated with ursodiol. And true to what we knew previously, the breakdown was just about 10% male and 90% female. But that gave us 446 male patients to study. And that's the biggest group of men with PBC that anybody's ever looked at. Plus the median follow-up was 7.7 years, which is a pretty long time. Out of that large group, there were a significant number of patients who died, either from their liver disease or other causes, or who were transplanted. And the good side of that is that when analyzing the data, it gave them enough deaths or liver-related events that they could analyze what factors were involved. So one of the things that this paper showed us was that males respond equally well to ursodiol as females. And it was previously thought that they didn't. So they proved that this was false. It was previously thought that they didn't, but that was based on very small numbers of male patients, 10, 20 at most. But with these large, robust numbers, they were able to show that males respond just as well. So if you're a statistician, you'll understand the analysis that was done at the bottom written for you. If you're not a statistician, the way to interpret this data are that they looked at every single variable they could think of that might influence how well somebody would respond to ursodiol. And one of the things they looked at was male sex. And the odds ratio was 0.77. So that means males were 77% as likely as females to respond to the treatment. That sounds a little lower, but the variability that you can see in the next column was big enough that there wasn't any statistical difference between males and females. And that's why the p-value is 0.09. So, so that was proved to be false. One thing that they did also find in this paper is that men are older by the time they start ursodiol, men with PBC. And here's the analysis that showed that. You can see they've grouped the patients into different age groups, less than 35, 36 to 45, 46 to 55, et cetera. And looked at the number of males within those groups. What was the percentage that was males? So in the younger age groups, only about 7% of the patients are male. But in the older age groups, 56 and 65 and older, it's more than 10%, almost 16% of the older people. So there's this enrichment in older males that are getting started on ursodiol. Now, why is that? Is it because the disease is milder and so it's not appearing really until males are older? Or is it because there are delays in diagnosis and we're not picking it up in males until much later? Well, this is a somewhat complex analysis from that paper. I'm going to do my best to explain it to you and walk you through it. But the bottom line is it shows that males have more advanced disease at diagnosis. So that means it's probably not that, that the disease is milder in men, but they're being picked up at a later stage. So on the y-axis of these graphs is the probability of a GLOBE response. And I'll show you in the next slide what a GLOBE score is. But basically, it's a measure of prognosis based upon how severe your liver disease. And you can see that regardless of whether you fit into the good prognosis group, which is the panel A, or the worst prognosis group, which is in B, the males have the lower curve. They have a worse prognosis based on having more advanced disease. This is just to show you what a GLOBE score is if you're not familiar with it. It is a predictor of survival. It's just a mathematical formula that you can plug in age, bilirubin, alkaline phosphatase, albumin, platelets. These are all, well, except for age, blood test results. And it will spit out a 3-year, 5-year, and 10-year prognosis. And this is available online for everybody to use. You just have to Google it. So what about their survival? So in this analysis, it did show that males have a worse transplant-free survival, okay? But it turns out that that is not because they are male. So in graph A, you can see just kind of crude survival. The females are the solid line on top and the males are the dotted line below. So they have a worse survival. But in B, if you adjust for certain factors, their survival is no different. So they adjusted for how old they were when they started the ursodeoxycholic acid, how old they were when they got diagnosed, and what their laboratory values were at the time of diagnosis. So what this tells you is if those patients, if those males had been diagnosed earlier, started on ursodiol at the same time that the women were, as well as when they had lower tests, their survival would have not been any different. And in fact, if you look at overall survival, one question that comes up is, well, maybe their survival is worse, but is it really from liver disease? Maybe they're more likely to die from, having a heart attack. We know that males are more likely to have coronary artery disease, or maybe they're more likely to get into a car accident. So they did break down the types of death and transplant and compared males and females, and there really was no difference. Maybe slight increase in liver unrelated death, but not statistically so. So you can see liver transplant in the dark color is pretty much the same, liver related death pretty much the same, and unrelated death. So that shows you that the cause of deaths are the same. So one thing, this is from a different paper, but the same global PBC group, but one thing that we do know, and this has been shown in multiple papers, is that males with PBC are more likely to get hepatocellular carcinoma versus females. And this graph is again from the global PBC group. So over 4,000 patients, 123 of them had hepatocellular carcinoma. And they looked at what variables predict whether they're going to get cancer or not. And the two most important things are whether you're male or female, and whether you respond to ursodiol, meaning your numbers, your lab tests improve a whole lot, or not. But you can see that being male is the worst prognostic factor. So even if you're male and you have a wonderful response to the medication, you still have a higher risk of developing cancer than a female who doesn't respond. And in fact, overall, men with PBC were 2.91 times more likely than women with PBC to get liver cancer. And that was highly statistically significant. And I would add that this is a feature that is not just unique to PBC. So we see this with hepatitis C, alcoholic liver disease, all kinds of cirrhosis. Males are more likely to get hepatocellular carcinoma. So the unfortunate truth is that men with PBC are not identified early enough. And this translates into starting ursodiol later in the disease course and at an older age, and subsequent poor survival. Males with PBC cirrhosis are 3 times more likely to get liver cancer. And really what I take away from this is that doctors need to be more aware of the potential diagnosis in men, and men with PBC need to advocate for their healthcare earlier. There's a lot of data, not specifically in PBC, but in healthcare in general, that men are less likely to seek healthcare. But this probably a dual responsibility between the patients and the doctors to make this diagnosis earlier in men. So for the battle of the sexes in the PBC, I have to say that the women win, all right? But it could be a tie if we could deliver better healthcare. There's nothing about being male and having PBC that makes you any higher risk for progression other than being diagnosed later. And if we, screen for hepatocellular carcinoma aggressively, we can find those earlier and manage those. So, and that's what I wanted to say.
That was so interesting. Thank you so much for that presentation. I don't think we've actually seen any of that data on any of our speaker series. So thank you so much for sharing that with us. And I think you have to stop sharing your larger screen. Yeah. And we'll call on Dr. Aliya to go next. There, you're good.
All right, can you hear me?
Yes.
Okay, great. Well, thank you for that. My task has been, and first of all, before I even start, thank you to Gail and the Canadian PBC Society for inviting me to speak today. That was a lovely talk, Marlyn. Thanks. It's nice to be able to follow you. So my task is to talk a little bit about PBC therapies, and just in terms of objectives for this talk, we'll take it sort of as a historical journey from the past to the present to future options that are available. And I hope that guiding you through these slides, you'll see that a lot has changed in PBC therapy in the last 5+ years, and a lot more will change moving forward, and the opportunities and the therapeutic options that are available to patients are changing all the time, and it's a really exciting time for people who treat patients with PBC to work because the landscapes are always changing, and we have much more to offer our patients than we did previously. So in terms of objectives, I'm going to talk a little bit about the role of ursodeoxycholic acid therapy, which I know is not new to this audience. And then we'll talk a little bit about novel therapies in PBC, particularly adjunctive agents, including drugs like obeticholic acid, the fibrate class of drugs, and then the role of combination therapy. And then we'll spend a few minutes talking about clinical trials and options for therapies moving forward. So this concept of response to treatment in PBC is probably something many of you have heard multiple times in your clinic visits. And what does that exactly mean? So when physicians are evaluating a patient's response to therapy in PBC, traditionally they're looking at their biochemical, or what blood tests look like after a year, usually a year of treatment with ursodeoxycholic acid. And lots of different groups all around the world have studied what's the optimal number that the blood tests improve by, particularly the alkaline phosphatase improves by, that's associated with improved outcomes in patients with PBC. And you can see here, there's a group in Barcelona that studied this. There's a few, this has been studied several times in Paris, and there's a few criteria by the Paris group that have looked at thresholds of improvement in blood tests that are associated with outcome in patients with PBC. There's the Toronto criteria, and then there's the Rotterdam criteria. And your physician might think about some of these criteria, all of them, or maybe even their own sort of version of these criteria when they're looking at whether someone's responded sufficiently to therapy. And I've highlighted the Toronto criteria, not because I'm biased, but I'm partially biased, but it's because it's one of the criteria that's been used in the clinical trials that have studied new agents in patients with PBC. And so that's a reduction in the alkaline phosphatase to less than 1.67 times the upper limit of normal after a year of therapy with PBC, a year of therapy with ursodeoxycholic acid. So I said that we're going to start historically. So why do we use ursodeoxycholic acid? So this has been used for many, many years in patients with PBC, and it's because we know that use of ursodeoxycholic acid in patients with PBC improves blood tests, and some of those blood tests are what we call surrogate markers of outcomes. So specifically, the alkaline phosphatase and the bilirubin are blood tests that we know when they decline are associated with improvements in patient outcome. And one of the problems with doing clinical trials in uncommon and slowly progressive diseases like PBC are that you need a lot of patients to have clinical outcomes like liver transplants or like liver dysfunction or liver decompensation to be able to show that a drug helps. So what we needed was blood tests to tell us what are surrogate markers, or what are markers that we can show in a short period of time that if they improve, these patients will do better. And so work from the Global PBC Study Group, which you were introduced to previously, has shown that improvements in the alkaline phosphatase and the bilirubin early in the disease course are good predictors of outcome in patients with PBC. So these are surrogate markers of outcome. And this is just data to show that while we know that some patients who are treated with ursodeoxycholic acid will have a complete response to ursodeoxycholic acid, i.e. their blood tests will normalize or near normalize, there are some patients that won't have a complete response to ursodeoxycholic acid. But even despite that lack of complete response, all patients with PBC benefit from therapy. So this is a survival curve that shows 3 lines. The line at the top shows the outcome, or the liver transplant-free survival, in patients who have a complete response to urso, and the lowest line shows patients who are untreated at all with PBC, who don't have exposure to urso. And the line in between are those patients who have an incomplete response. And the fact that the patients that have an incomplete response still do better compared to those patients that are untreated emphasizes to us that urso is good for everybody with PBC. And once you're diagnosed with PBC, you should be on ursodeoxycholic acid, and you should be on that forever. But we also know that, like I mentioned, a proportion of patients won't respond perfectly well to urso. And while they do better than if they weren't treated at all, there still is a gap between those that respond well and those that don't respond perfectly well. And you can see again here, these are survival curves that show that patients who respond to ursodeoxycholic acid have a pretty good outcome that oftentimes mimics that of the general population, whereas those who don't respond perfectly well to ursodeoxycholic acid tend to have a worse outcome than those that do. And I mentioned this earlier, this is work from the Global PBC Study Group that shows that alkaline phosphatase and bilirubin are validated surrogates of outcome. And this data was hugely important for the field of therapeutics in PBC to move forward, because it allowed regulatory bodies like the FDA, the EMA, and Health Canada to say that, to agree to approve drugs along an expedited pathway if new treatments showed an improvement in these blood tests in patients who were treated with new agents. So instead of waiting for liver transplants and outcomes like liver cancers or liver failure, all we had to show was that an improvement in alkaline phosphatase and stabilization or improvement in bilirubin was achieved with new therapies. And that is what has resulted in us having all these new drugs available to us. So what are these second line options that are available? So before, in Canada, at least before 2016, we only had ursodeoxycholic acid as a therapeutic option. But based on this work from the Global PBC Study Group and then clinical trials, new drugs have been studied. So this is data that was published in the New England Journal of Medicine in 2016 that studied obeticholic acid in addition to ursodeoxycholic acid in patients with PBC. And the graphs, the details of the graphs aren't that important, but what I'll bring your eyes to is the blue and the purple bars, which show that patients that were treated with urso as well as obeticholic acid had a higher proportion of them had an improvement in their alkaline phosphatase and bilirubin than those who were just treated with urso on its own. So up to almost 50% of patients that were treated with the combination of drugs had an improvement in their ALP to less than 1.67 times the upper limit of normal and a reduction in their bilirubin compared to those that were just treated with urso on their own. And so this study met its endpoint of showing an improvement in those blood tests that predict patient outcome. And while a study is done for a short period of time, we can't generally keep people enrolled in studies for years and years and years. But what the POISE study showed us was that this improvement in blood tests is possible in the short term. And what we've learned over longer periods of time in evaluating these patients that were in the study over a longer duration of time is that this response with obeticholic acid is durable. So once you get that improvement in the ALP after using combination therapy with obeticholic acid, generally that improvement is sustained over time. And what we also know is that patients that participate in clinical trials aren't necessarily exactly the same as patients who don't participate in clinical trials, because there's lots of reasons that patients either aren't eligible for trials or choose not to be a part of clinical trials, be that because of where they live or access to study centers or willingness to participate in studies. So what the next line of data shows is that what happens to patients that are treated with these new drugs in the real world. So we collected data from our center in Toronto and from several other centers across the country to look at what happens to patients who are treated in the clinic with combination therapy with urso and obeticholic acid. And what we found is that patients treated with combination therapy with urso and Ocaliva do pretty much similarly to what we saw in the clinical trials. It's not exactly the same in terms of numbers, but you can see the gray bars at 6 months, at 9 months, and at 12 months show that patients who are treated with combination therapy do meet those endpoints that were seen or that were looked at in the clinical trials as well. So this is good evidence to show us that, at least in our experience, that we can treat patients with this combination safely and effectively and expect responses that are not dissimilar, not entirely dissimilar to what we saw in the clinical trial. And while we did our study locally, we've also looked at this data, and this hasn't been published yet, but it's accumulated data from the Global PBC Study Group that showed very similar results, that even across the world in patients that are treated with combination of urso and Ocaliva, the biochemical response is pretty much as you would expect and is durable over time as well. So that's one option for second line therapy, but then you might have heard, I'm sure you've heard about another class of drugs called the fibrates that are also being used as second line options. And one of the differences between obeticholic acid and bezafibrate is that obeticholic acid has obviously been studied in clinical trials. Bezafibrate has as well, but bezafibrate the fibrate class of drugs hasn't gone through the regulatory process of getting approval by the FDA, the EMA, and Health Canada, because it's available on the market in many countries. It's not available, bezafibrate specifically, I don't think is available in the United States currently, but it's available in many provinces in Canada and in Europe. So this is data that shows that bezafibrate used with obeticholic acid also results in improvements in those surrogates of outcome that I mentioned before, particularly the ALP and the bilirubin. And here in the chart on the left, you can see the bar graphs that show about 30% of patients that are treated with bezafibrate, in addition to ursodeoxycholic acid, had normalization of their alkaline phosphatase when they were treated in this clinical study. So also good evidence to show biochemical improvement. And this is data that was published just recently that showed while we like to see improvements in surrogate outcomes, we also want to know that these therapies are helping patients not only with surrogates of outcome, but also with hard outcomes like liver transplant. So this was published by the Japanese group and also by the French group that showed that liver transplant-free survival is improved in patients treated with urso and bezafibrate in a higher proportion than those treated with urso alone. So what about combining all of these agents together? So this concept of triple therapy. So there are a proportion of patients who won't respond perfectly well to urso with obeticholic acid or urso with bezafibrate. So what happens if your liver tests are still elevated despite the fact that you've been on 2 agents? So this was data that was presented at a meeting a few years ago now that showed that in patients who still had elevations of their liver numbers despite therapy with urso and obeticholic acid, when you added bezafibrate or so-called treated them with so-called triple therapy, their liver numbers further improved. And we'll start to see more and more data about that in the coming months and years, I think, that this concept of triple therapy can improve blood tests in high-risk patients, i.e. those patients that have persistent elevation of liver tests despite using 2 drugs even. And this is data that again, these graphs that you just saw in the slide before, and data from the global PBC study group that shows that in patients that were treated with triple therapy, the alkaline phosphatase continues to improve. So maybe there's a role for the combination of urso and obeticholic acid and bezafibrate in combination for patients who have difficult to treat disease, i.e. their liver tests remain elevated despite escalation of therapy. So what about future options and directions? So I hope that I've already given you some insight into the fact that therapies are available even if liver tests remain elevated on urso, and several different options are available, but there are more options that are still in the pipeline. And this is one example of a drug that has been studied and continues to be studied in patients with PBC that's called seladelpar. It's a mechanism of action that's not exactly like, but similar to bezafibrate. And this was early data from a previous study that showed that even at 3 months of therapy, treatment with this drug called seladelpar showed an improvement in blood tests in patients with high-risk PBC, and also an improvement in itch. So maybe drugs are available not only to improve blood tests or biochemistries, but also symptoms. This is another drug that's a similar mechanism of action called elafibranor that also has been shown to improve blood tests in patients with high-risk PBC, and is another one that continues to be studied. So in terms of take-home points, what I'll say is that urso, I hope I've emphasized to you that urso is important for all patients with PBC, and upon diagnosis, all patients with PBC should be treated with urso. Second-line therapies are next generation therapies are increasingly available, it's important to know why, while these agents can be used on their own, in general, they've been studied to be used in addition to ursodeoxycholic acid, not in replacement of it. And examples that I've mentioned include obeticholic acid, fibrates, particularly bezafibrate. There's combination options of the two drugs above, and there's new agents that are being studied in clinical trials. And the landscape of PBC therapy is rapidly changing and evolving. So keeping the lines of communication open with your provider is important, and advocating for the best therapy for you, which needs to be individualized, is also very important. So with that, I will end. Thank you very much.
Oh, that was wonderful. Thank you so much. Each time I hear the presentations, I truly learned so much. I hope everybody else did. We had one question that I think I'll just ask you now, Aliya, while you're on the thing. I think,
Sure.
Can you turn your, oh, I guess I should too. I think when we shared the screen, all our cameras went off. Now they're back on. The question was, should people who are post-transplant be on URSO?
Oh, very good question. I always am surprised with the caliber of questions that come through these forums. So yes, all patients with PBC who have a liver transplant should be treated with ursodeoxycholic acid post-transplant. And while many centers did this previously, this was re-emphasized in recent data that was published that showed that patients who are treated with ursodeoxycholic acid preventatively have better outcomes in terms of graft loss when they're treated with URSO post-transplant. So the standard of care now should be that immediately upon transplant that URSO is restarted. Or it's not stopped at all.
Thank you. Okay, now I'm going to turn things over to Dr. Tandon. So hopefully she can share her screen.
Yeah, I'll just share my screen. Let me know if that works, Gail. Can you see that?
Yeah, yes, it's good.
Awesome. Okay, so thank you, Gail, also for the invitation today. And I'm going to be following off those two beautiful talks to look at some non-pharmacological therapy that we can use in addition to our pharmacological management. And just wanted to wish happy International Women's Day to all the beautiful, powerful women who are listening. All right, so well-being. We know well-being's complex. There's many, many aspects of well-being that are affected by our physical health, psychological input, social interactions, financial and occupational things. So many, many inputs that are a complex interaction that lead to how we feel every day and how well we feel every day. We also know that there is a real interaction between the mind and the body, and these things are not separate. So for example, if we are worried, anxious, depressed, we can feel that in our bodies. We can feel tightness, headaches. If we have symptoms like itching, fatigue, chronic pain, again, that'll impact our mental state. So again, a really complex interplay. And not surprisingly, symptoms of anxiety and depression are common in people who are living with primary biliary cholangitis. So about 2 to 5 times more common than in healthy controls. And this is similar to other chronic conditions. There's also in studies shown increased rates of what we call psychological stress. Okay, so stress. Stress is another very interesting topic to talk about. There's acute stress and then there's chronic stress. So acute stress is that bad? And it's not actually a bad thing. It's a physiologic mechanism to protect us from harmful things that, you know, in the past may have been a threat to us, a threat to our life. I've just put in a short little fun video of a time when I was actually under tremendous acute stress. And I'll just show you this. So this was a skydive that I did. So this was actually really important for me to be very focused at this time and all of the physiologic mechanisms to be activated. We'll just show you what that looks like. absolutely, when that's happening, stress is important. Our body's ready for action. Our adrenaline's released. Our blood pressure goes up. The liver releases glucose to provide energy for the muscles. We don't focus on digestion much. Our heart's pumping. The problem comes, though, when we're skydiving multiple times a day. And that leads to multiple demands that exceed our ability to cope. And then we're in that state of emotional and physiological reactions. That's called chronic stress. And so we all know there's many, many things that are these kind of skydive moments during the day that can impact us. And having a chronic condition is one of those things that is a constant worry for many people. Untreated chronic stress is significant because it can contribute to things like anxiety, difficulty sleeping, muscle pains, high blood pressure, impaired immune function, as well as studies have shown even worsening cardiac disease and weight gain. So I'm going to show you two studies that I like. They're really older studies, but it really speaks to the point that we do need to consider our emotional health when we're talking about full person management, because it does impact our bodies as well. So this was a study that was done in 1992, and it looked at the effects of anger on left ventricular ejection fraction. So that's how well your heart pumps. And so what these investigators did is they brought people in and they said, okay, we're going to put you through some acute stress. We're going to put you through exercise or math, which would be horrible for me, or we're going to accuse you of shoplifting and see how you defend yourself against that, or we're going to get you to recall an incident that made you really angry. And what they found was that the anger recall, so when you were thinking back and thinking, oh gosh, I was so angry at that person, that actually reduced heart function more than any of the other stressors. 40% of patients had a significant reduction in the ability of their heart to pump. And when patients were asked, the intensity of the anger with the experiment obviously couldn't mirror exactly what it was at the time of the actual event. So just to show you that, again, our emotions, if we can figure out a way to better manage those, that really may have impacts just on our overall physical well-being. Similarly, another interesting study around emotional style and susceptibility to the common cold. So this was 334 adult volunteers. They did questionnaires on them to say, okay, are you more of a negative emotional style or more of a positive emotional style? And they had all of these people at a hotel that they had used for the study. So they dripped rhinovirus, which is the virus that causes the common cold. So they dripped rhinovirus nasal drops into everyone, and they saw who objectively developed a cold and who subjectively said, yeah, I'm having cold-like symptoms. Positive emotional style was protective against developing a cold. So you can see here the white bars, high positive emotional style, less colds. And we know this, we're tired for a few days in a row, boom, more risk of getting kind of viral infections and other things. So again, that connection between our emotions and our body that really can't be ignored. So with that in mind, and with multiple requests from our patient partners to say we really need something to help us with managing the emotional part. Yes, we're going to take our medication. Yes, we realize that's really important, but we have a lot of other stuff that's going on with our emotions and our mental state. So we brought together and really researched and thought about what are the best practices to do that. And there's certainly lots of practices from the East and lots of practices from the West. And so practices from the East would include things like mindfulness, which you will have heard about. So meditation, being aware of the current moment, yoga type of postures, Tai Chi, and breathwork practices. So really getting in full inhalations and full exhalations. In the West, things like exercise. Exercise, one of my collaborators says, is the drug that has not been bottled. So it has impacts not only on your mind, but also on all parts of your body, from your heart to your lungs, to your muscles, to your bones, to your immune function. So it really, exercise is an incredible tool for managing mental distress. There's also psychological interventions like cognitive behavioral therapy, or CBT. And one that we have been using, as I'll show you in a program this program that we've created with the help of a psychologist, Dr. Dana Lee Bagley, is acceptance and commitment therapy. And so that's accepting that you're going to get angry, accepting that you're going to feel worried, accepting your reactions, acknowledging your reactions, being aware of them, knowing what your values are and choosing a valued direction to be able to take action when those things do come up. So you are acting more in line with your values. So really, you can see how combining these things may be very interesting to offer people a real menu of options. Now, is this based on evidence? I'm going to show you just a few quick slides on this, and this is a whole in-depth talk on itself, but looking at things like yoga, it's had an impact on inflammation, yoga impact on exhaustion levels and fatigue, impact on immune system functioning. This study on Tai Chi that I pulled looking at impacts actually on the atrophy of gray matter in the brain in older adults. So some protection from things like cognitive decline or dementia. Breathing, those deep belly breaths, even 15 minutes a day, reducing pro-inflammation, reducing anxiety, improving attention, reducing stress. So, and these are just sort of a handful of the studies that I've chosen. Other studies looking at the impact, very interestingly, just on the brain itself. And so there's ways that we can study the brain by MRI, and we can look at the connections that are made. So how different parts of the brain talk to each other, but also the structure and the size of parts of the brain. So within 2 weeks of doing regular mindfulness meditation practices, things that show up, improve focus and memory in many studies. And within 8 weeks, you can actually start to see changes in the brain itself. So things like increasing the gray matter in the parts that it matters, where the hippocampus, for example, where you get memory and learning and attention, and actual decreases in this volume in the amygdala, which is your fear and anxiety and stress center. And so that's within about 8 weeks of just doing a regular practice. This study I really like. It's very interesting looking at breast cancer survivors. And so what they did is they did, again, a mindfulness-based intervention with meditations and a few other components. And they looked at telomere length. And so telomeres are the little caps on your chromosomes, and those go down as we age. They go down with distress and stressful events. And what they found was that the telomere length was actually maintained in these yellow people, the intervention people, as compared to decreased in the control. So again, real physiologic effects of these practices. All right, so let me introduce just a short little intro to the program that we created with the help of Gail and Shona, who's another patient partner in PBC, and many other people, and Michaela Watt, who's a master's student who's helped to run this out. It's a 12-week program that we've been trialing. And the first version of the program had standing yoga postures, some breathing practices, meditation, and some behavior change activities based mainly on cognitive behavioral therapy. And this pilot study started in January of last year. It was a single arm, which means it's not controlled, which has some limitations, but we were doing it as a feasibility to see, can this actually be done in PBC, and acceptability study. So is it acceptable to participants? And we had 32 people sign up from Alberta and British Columbia, mean age of 58. And all of our participants in this study were women. And so just to take you through some of the very basic results, this hopefully will be published soon, but recruitment was reasonably quick with Gail's help. 29 out of 32 participants got to the end of the 12-week program, and 25 out of 29 actually did manage to do the program at least 2 to 3 times per week, which is what we set as the goal. We got a lot of acceptability data around which parts of the program did you like, which parts can we do better on, and so this is just a sample of some of the very satisfied with the different parts of the programming. And then again, with a single arm, it's difficult to actually look and see for sure about, and such a small study, it's difficult to say that there's an impact on clinical outcomes, but this was an exploration from pre to post. And what we saw that there was 30% reduction in anxiety and depression, 15% reduction in stress measures by a survey, even a 13% reduction in fatigue and some improvement in PBC-40 symptoms. And I think probably one of our favorite pieces of this was the qualitative work that came afterwards. And this is a really important part of these studies, to be able to hear the voice of the patient after they're done the study, to say, what did you like, what didn't you like, and what impact did this have? And so this is just, I put up a few of the quotes from this particular pilot study that we did. This idea of having an inside head voice that's constantly running a stream of negative thoughts, and that the program actually helped to deal with that inside voice. This regain in energy and focusing on the things, again, that were consistent with that person's values. So focusing on their health for maybe the first time, that the changes were small, but the impact was powerful. This awareness really came out in a lot of the qualitative work of awareness of emotions. So when they're starting to feel stressed, they've got some tools that they can use in their toolkit to actually decrease that and reduce that burden that happens on the body and the mind with that. And then we learned a lot about, you know, how people feel when they're living with PBC. And so I'm just putting just a few quotes here. We have hundreds, but PBC is an illness that most people don't know about, and it can be isolating. So as part of this program, what Gail and Shona did is they introduced some group sessions where once a month, the participants were invited to meet together. And I think that experience was super helpful, as we heard from not just this participant, but many others. Now, with that feedback, we have also started a randomized control trial. And this is a stronger study design, which means that you have not only a intervention group where they're getting the program, but you also have a control group. So you can see, does the control group also improve? And that's a much stronger way of evaluating this. And we made some changes on this based on feedback. So we introduced a little bit of gamification where the participants would get points. We expanded the movement offerings. And so to account for the fact that not everyone can do standing yoga postures, introducing a chair arm and a Tai Chi arm. And we really revised the psychological content. I think this has been one of the favorite pieces. So this is actually based on, like I said, acceptance and commitment therapy, but it's an excellent program over the 12 weeks where our team psychologist really takes you through the tenets of acceptance and commitment therapy, about pacing, about values, and about living a value-directed life. So we've got 92 participants from across the world who are currently taking part, and we have learned a ton from the first cohort that's gone through, so that we can actually make revisions again. And so we've got, happy to announce, we're going to have another large program coming out with a lot of excellent feedback that we've gotten, and that'll hopefully start in September of this year. And I'm sure Gail will send out announcements about that. And so my take-home points: stress, anxiety, depression, these are common things. And we need to also think about these as healthcare practitioners and bring these up, I think, in our appointments with our patients. They significantly impact well-being. In addition to medication treatment, there's a variety of science-based strategies that I've shown you that can have a positive impact to support emotional health and well-being. And I invite you to stay tuned for future programming, and we'd really love for you to be a part of it. So thank you, Gail. I'll stop my share.
I'm going to unmute myself. That's Leah. I'm trying to unmute myself.
You're muted.
You were unmuted, Gail, but now you're muted. There you go.
There I go. Okay, I was just saying the program's wonderful. I've been through it twice or three times. I can't remember how many times. And we put out a pre-registration request, and we have 50 people on our waiting list for the next round in September. And hopefully once we open it up, further to our US friends and patients, then we're going to have a lot more interest. I have a couple questions. One one for Dr. Tandon, which is about stress and hair loss. But I think maybe a more general question is, does stress cause some physical things that people sometimes associate with PBC or medication?
Yeah, and absolutely it might. It's really, like I was making the point, it's really difficult to disentangle, I think, the mind and the body effects. So emotional distress can have a lot of impacts, hair loss being potentially one of them. Yeah.
Right. Okay, and a question for Dr. Mayo is men, women, and how about the relationship between their relatives, like the children of women or versus the children of men? Do we know anything about that?
I don't think we know anything about the children of men. We do know that men with PBC, their chance of having a first-degree relative, so not their children, but their brothers, sisters, mothers,
okay,
is about 6%, which is slightly higher than it is for females, which is about 4%. So ever so slightly, they are more likely to have a family history. Yeah.
Interesting.
But I don't think anybody's published about men's children yet.
Right. Okay. It was not surprising. Dr. Aliya, how about, is OCA ever an alone therapy?
So that's a good question. It has been studied in small numbers of patients as monotherapy without URSO in patients who don't tolerate URSO. So the vast majority of patients with PBC will tolerate URSO, but a small minority will not, either due to side effects, be they GI side effects or other things. So it has been studied in a small minority of patients as monotherapy and can be effective used on its own, similar to the fibrate class of drugs.
Okay, and a follow-up from the post-transplant therapy, would there ever be a combo therapy for those patients?
Yeah, what a good question. So would there ever be combination therapy post-transplant? I can't see why not. I think it would be very difficult to study because it's such a small number of patients that that would require that. So the huge good piece of information is that with URSO, deoxycholic acid, and with second-line therapies available, the proportion of patients that are requiring transplant for PBC is decreasing over time and has decreased over time. And most patients with PBC do marvelously well post-transplant. Furthermore, if you're treated with ursodeoxycholic acid right away, the risk of recurrent disease post-transplant is low. And most times recurrent disease takes a long time to become a clinical problem. So if liver tests remain significantly elevated early on post-transplant and there's worry about recurrent PBC, for sure everyone should be on URSO. Would your physician think about adding a second-line therapy? I can't see why not. I don't think it's been, to my knowledge, I'm sure it's been used in a few patients here and there, but it hasn't been published to my knowledge at least. But it's an option. It's certainly a therapeutic option that would hopefully be necessary in a very small number of patients.
Okay, thank you. I have one last question. I don't want to put you on the spot, but if any of you would like to tell us, why did you get into hepatology, or this, what interested you about the liver? Was it a first choice, a last choice? What brought you on this path?
I'll answer.
Okay.
So I didn't always start off thinking I wanted to do liver disease. When I was in my training, of course, in order to be a hepatologist, you have to first be a gastroenterologist, and before you're a gastroenterologist, you have to be an internist, right? So I was doing my internal medicine residency, and I actually was interested in doing rheumatology because I was very interested in autoimmune diseases, simply because I just thought it was fascinating. Why would the body attack itself? That makes no sense whatsoever. It shouldn't do that. The body seems much more sophisticated than that. And also I felt like I could relate to the patients because they were often female like me. They were, often my age. They had not you know, done anything particular to incite their disease that they were aware of. So I really felt like I could relate to the patients. But I think the one thing that really pushed me into doing hepatology was just I had a great mentor. When I was a resident, I had a, when I did my GI rotation, I had a attending, his name was John Haves. And he was a brilliant hepatologist, and I learned so much from him on rounds. And he always made us, you know, read a lot, and he was dynamic. He was just passionate about what he did. And he said, Marlyn, you ought to consider going into like GI and liver disease. And I was like, nah, I'm interested in rheumatology. I like autoimmune diseases like scleroderma and lupus. And he says, well, there's some liver diseases that are autoimmune. You should go read about like PBC and PSC and autoimmune hepatitis. And then, of course, he made me give a talk on that. So I was like extra work. But after that little exercise, you know, I realized it was kind of interesting. So he was really the one that kind of guided me in that direction. And I still see him. He's retired now, but he still comes to like the AASLD liver meetings, and I'll still see him, and he's very proud now.
Listen, anybody else want to throw in their comments?
Well, I'll quickly say that I trained in the era, well, early on in my training with Dr. Heathcote, and she said more than once that we'd be stupid to think we wanted to do anything else. So I think some of us at least were forced into this pathway through, well, forced, but through exactly as Dr. Mayo says, through amazing mentorship and through visionaries in our field that really were inspiring to be around and learn from. So mentorship is a huge part of why I am where I am.
Yeah, I'll echo that too. So my mentor has been Spain and Lupe Garcia Sao over at Yale. So those two really brought me into cirrhosis, actually, which is my primary area of focus. And just what drew me to that is all the gaps in care and the high symptom burden, and just a multi-system disease, and trying to see how we could do better. So.
Awesome. On that note, I'm going to wrap it up. And I just want to thank our speakers tonight for everything that you do to support your PBC patients, including compassion in your clinical work, but also, and I think this ties in with what you've said about how you got into hepatology, is your dedication to research and teaching, so that we have the next generation of PBC specialists coming up under you. So you give us hope for the future and confidence in the present. And I'd like to thank our sponsors tonight, Intercept Pharma and CymaBay Therapeutics, for their generous sponsorship of the speaker series. And I'd like to thank everyone who attended the program this evening. So thanks a lot for everyone. Tomorrow we'll post it on YouTube for those who missed it. It'll stay on the Facebook page. Like it and share it. And I hope you learned a lot. And I know I do every time I hear these presentations. So thanks so much.
Thank you very much.
Thanks.
Thanks. Have a good evening.
Bye.
Bye.